I'd like to thank the organizing committee for inviting me. I'd like to start out with, this is the list of the people who've done the work that I'm going to report on today. This is going to be going back over a few years and discussing some principles that I think are important to keep in mind in doing aortic surgery if one is going to apply the technique of hypothermic circulatory arrest. On the left of the list is, on the top is my major collaborator, Eva Griep, and on the left is the surgeons that I've had the privilege to work with over the years, and the other two columns are the very talented young people who've done so much of the scientific work in our laboratory. Now, deep hypothermic circulatory arrest is a strategy for operating on patients who had difficult areas of the circulation to access. Was really probably conceptualized by Bigelow back in 1950 or so, and was actually applied by Lewis in 1952 and 53 in Minnesota, F. John Lewis, and then by Drew, who really introduced it into a widespread pediatric use in about 1960. This was the first series of patients in which hypothermic circulatory arrest was applied to. Aortic disease is the one that we had the privilege of publishing in 1975. Now, in applying hypothermic circulatory arrest nowadays, now that we do have a better understanding of the physiology and so on, it is helpful to go over some of the basic physiology limitations and so on of the technique. And this is a study done in pigs in which one can easily measure the metabolic rate for oxygen in the brain by sampling the arterial blood, the sagittal sinus blood, and then measuring blood flow with either radioactive or fluorescent microspheres. And this gives you a very good picture of what one sees in the experimental animal. This is the pig. It's also been done in the dog. Some others have done it in primates. And one can see that as the temperature has dropped here from 27 down to 8 degrees or so on, there's what appears to be pretty much an exponential drop in oxygen consumption. And this does appear to be a fairly consistent physiological observation that in these ranges of temperatures that the relationship between oxygen consumption and temperature is a semi-logarithmic or an exponential one. And so one can plot, as one sees in this slide, the relationship of oxygen consumption to temperature, generate a line, take the slope off that line, and that line is the so-called, we can call it the Q10, you could use any other interval, but that's the most convenient one. The ratio by which metabolic rate changes for each change of 10 degrees in temperature. And this is again done in the experimental animal here. And the Q10 comes out in this particular experiment of about 2.5, with 95% confidence interval from 2.1 to 2.9. Now it's a little more difficult to do this in man, but one can make an approximation, and that's this next couple of slides show one can measure arterial O2 content reasonably well, or reasonably easily. Cerebral venous, mixed venous oxygen content can be estimated from jugular bulb samples, and one can estimate at least relative cerebral blood flow by placing a flow probe in man on the left carotid artery. And this was done in a series of 37 patients who needed surgery requiring HCA as part of their surgery. And this is a composite graph of hemodynamic changes, metabolic changes that occur in man with the drop in temperature. And it's interesting to look at it. You see here as the temperature drops, this is at first off cardiopulmonary bypass and the last 3 points on bypass. One can also see, if we can go backwards, at the bottom here, it's not going to work. At the bottom of the slide, you can see CMRO2 going down, the cerebral metabolic rate for oxygen. And cerebral blood flow, you can see, goes down along with that. Autoregulation actually works in man pretty consistently all the way down into low temperatures, at least during cooling. During the period of warming, however, one can see that although metabolic rate comes up relatively slowly, again, fairly tightly bound to temperature, cerebral blood flow goes up much more rapidly. Autoregulation is lost after an ischemic interval. There is reactive hyperemia. So there is some excess danger of embolization at this point because cerebral blood flow is higher than it needs to be. But this is only for the first first half hour or so of warming. Here's the analysis on these patients was done, similar to what I showed you earlier on the experimental animals. And again, you can generate a line for each individual patient of the logarithm of oxygen consumption against temperature, and then derive this sort of table for safe intervals of interruption of circulation at various temperatures. And as you can see, this is based on the idea that arresting the cerebral circulation for 5 minutes at normal thermia is consistent with recovery of normal cerebral function. And if one accepts that, then one just applies these ratios derived from the Q10 calculation as to what is the safe interval of circulatory rest. As you can see, at a level that most of you would consider really quite profound hypothermia, down around 15 degrees and so on, the maximum safe interval, according to this calculation, is still only 30 minutes. This was kind of surprising to us because at the time we did these studies for years, we had done clinical cases going up to an hour of hypothermic circulatory arrest, and for the most part, patients seemed to do quite well. However, when we started looking a little more carefully, we saw that this probably wasn't the case. And this is a study done in patients who had, some who had routine cardiac surgery without HCA, some who had, and then varying intervals of HCA. And when careful cognitive testing was done preoperatively and then several weeks postoperatively, these were the results. And what I've shown in looking at attention, processing speed, memory, and so on, et cetera, that once you got out beyond about 25 minutes, there were perceptible and measurable changes, odds ratios of 3.5 for memory, 11.1 for fine motor functioning. It wouldn't be a good idea to be a heart surgeon and have more than 30 minutes of circulatory arrest. So this again suggests that there are limitations. And there are some other observations, but as many as you have also done in the past decade or so, the use of near-infrared spectroscopy has made it to have possible to have some sort of monitoring of the status of the brain during circulatory arrest. One can see in this representative slide that during the period of circulatory arrest, there's quite a precipitous drop in the saturation of what's probably a mixture of venous and arterial blood in the brain. And you can see in this particular patient, these for the two sides, measured on the two sides, the saturation dropped down to between 50 and 60% at its nadir. As we began following patients of this sort, we could see that we were reaching this nadir of reaching the level of about 60% saturation in the brain, somewhere between about 25 and 35 minutes. This is another way of looking at the same thing. These are lines and individual patients. The dotted line is the composite. And you can see that when we reach 60 minutes or 60% saturation as measured by absolute cerebral oximetry, that occurs that's most likely to occur somewhere about 30 minutes. And when one looks at outcomes from the surgery, starting at about looking at those patients who had intervals in which their cerebral saturation was less than 60% for more than 30 minutes, one began to see an increase in the risk of an adverse outcome. and odds ratio went from about 1 at about 35 minutes, 5 minutes on this slide, up to about 2 by the time one had added another 30 minutes of circulatory arrest. We had also noted that doing prospective assessment of temporary neurological dysfunction, that we also did seem to see a change somewhere around half an hour of circulatory arrest. So this is the evidence that we have at the present time that 30 minutes of circulatory arrest at somewhere around 15 degrees or so is probably the safe, is safe, but if you have to go beyond that, and it's sometimes unavoidable, there probably is a price to be paid. And these are the factors that they're the studies that I've just discussed with you, the calculations of cerebral oxygen consumption, incidence and severity of temporary neurological dysfunction, and then cognitive function, and then monitoring by near-infrared spectroscopy. Now, as more surgeons got involved in aortic surgery and so on, more and more of us ventured into the even more challenging area, I think, than the ascending aorta and the arch in some ways, and that's the thoracoabdominal aorta. And the question of spinal cord protection and spinal cord tolerance to ischemia became important. And many of us, as many of you know, had become convinced just on clinical observations that patients who were kept a little cooler during operations on the descending thoracic and thoracoabdominal aorta seemed to have maybe a little less risk of spinal cord damage. And a few years ago, we thought we would try and investigate some of this in the experimental animal and in man. This is a very simple experiment that was done early in this decade, in which we took pigs and cross-clamped the aorta distal to the left subclavian artery at 2 temperatures, at normal thermia and 32 degrees. And as you can see here, that 20 minutes, all the animals woke up normal, had normal hind limb function. And this was confirmed by some histological findings. At 25 minutes, at normal thermia, one began to see some evidence, significant evidence of spinal cord injury. We didn't do all of the normal thermic animals through the longer periods of time. There didn't seem to be any point. But even at 50 minutes, at only relatively mild degrees of hypothermia, 32 degrees, the pigs still recovered normally. And it wasn't until we got to 60 minutes that we saw neurological injury, in this case manifested not by immediate, but by delayed paraplegia. Now, it's difficult to do a cross-clamping experiment at lower temperatures than that because you have problems with the heart beating and so on. So one then has to go to study using selective cerebral perfusion, in which the perfusion to the upper body is provided by a heart-lung machine rather than the heart. Based on the experiment that I just showed you, if we just had 2 points on each line, 2 points that were unsafe and 2 points that were safe, and we drew these sorts of lines of the semi-logarithmic plot of temperature versus safe interval of circulatory arrest. And one would predict on this basis that, say, at 28 degrees or so, which we thought was interesting because that was a temperature that many had started to use for selective cerebral perfusion, it would be safe to go up to 90 and maybe even longer in terms of preserving spinal cord viability. However, and you can see this 28 degrees, if one projects a line across here, one would still be in the safe area out at 90 minutes. Now, this slide I'm just showing you basically to demonstrate these are blood flow studies done in the pig during selective cerebral perfusion. And what's important is that selective cerebral perfusion, like is probably undoubtedly true during simple aortic cross-clamping, there is no cord perfusion below about T10 or so. So that part of the spinal cord is basically completely ischemic during selective cerebral perfusion. Now, when we looked at this series of animals perfused at 28 degrees and then with varying periods of selective cerebral perfusion, what we found was that at 90 minutes there was a 60% incidence of paraplegia, and at 120 minutes it was 100%. So this curve wasn't quite as, this relationship wasn't quite as linear as we thought, but still we did have some additional points based on this experiment, clinical observation, and so on, that allowed us to construct this particular graph that gives you a reasonable idea of what the safe ischemic tolerance of the spinal cord is. And when you put a number of these experiments together, one comes out with a Q10 for the spinal cord that is actually very close to what it is for the brain, somewhere around 2 or 2.2, 2.3. But the ischemic tolerance of the spinal cord is about 4 times longer than the brain, because at 37 degrees, the baseline is 20 minutes. You can go for 20 minutes of normothermic ischemia of the spinal cord in man from some clinical studies, and in animals from very rigorous studies. That's quite safe. So with a Q10 of about 2 to 2.4, something like that, you get these sorts of numbers for what is actually quite safe intervals for depriving the spinal cord of its blood supply, as you're going to do with either simple aortic cross-clamping or selective cerebral perfusion at higher temperatures. So these are sort of the take-home lessons for hypothermia and ischemic tolerance of the brain and the spinal cord. There's a relatively simple relationship. The relationship for the nervous tissue of the cord and the spinal cord appears to be about the same, or the temperature-time dependence, but as I mentioned, the baseline is different. And as a simple rule of thumb, if you just want to use a Q10 of 2 for any given temperature, this will always give you a safe ischemic time, both for the cord and for the brain. What about other parts of the body? Well, it appears that the abdominal viscera usually are more tolerant of ischemia than the spinal cord is, and usually those are exposed together. Although people have been seeing at higher temperature selective cerebral perfusion, visceral damage does become an issue in some cases, and there is an interplay between, acute injury and long-term injury from the acidosis and the reperfusion issues that do go on. Now, the big problem about hypothermia is, what about bleeding? That's what seems to be the big bugaboo. Many of us that have used a lot of hypothermia are not convinced that bleeding is a lot worse after the patient's been exposed to hypothermia. As far as I know, there are no good data doing head-to-head comparisons. This is a comparison that I like to show, which suffers from the problems of anything where you're comparing patients from one institution to another. But if you look across the top row, there's the temperature at which selective cerebral perfusion was carried out. And in the bottom row are those series in which the take-back for bleeding incidence was reported. And you can see, at least here, in this sort of comparison, there didn't appear to be any advantage of using a higher temperature. We recently looked at a series of our own patients, and they're shown here, in which this was about 240 patients, 77 of whom had distal aortic surgery with hypothermic circulatory arrest. And when you compare all the HCA versus non-HCA patients, we do see a difference in the amount of platelets transfused. When the propensity matching is done in subsets of these patients, these differences disappear. So there may be some difference. I'm personally convinced that the coagulation defect of hypothermia is platelet function, and that this can usually be reversed with platelet transfusions. But it appears in our own series in which the patients were operated on pretty much the same. Hypothermia was selected based on anatomical considerations, that we did not see more bleeding or transfusion in the HCA patients. Finally, practical tips. At the end, what's important about hypothermia, how does one implement it, and so on. These are the factors that I think are quite important. Not having too wide a temperature gradient between the blood and the tissue being cooled. In this case, the brain is what we're most worried about. Thorough cooling is important. We think this takes at least 30 minutes if you're going to go down to profound level. And it's nice to be able to assure that you have thoroughly cooled the brain. And the method that we have used over the years and are convinced is quite effective is looking at the jugular venous bulb saturation and waiting until this reaches 95%. Now, if you do oximetry with NIRS and you have a correction for absolute values, going up to 85% seems to be just as good. The HCA interval shouldn't, if at all possible, exceed the maximum tolerance based on calculations in the Q10 or on decrease of the cerebral oxygen saturation by NIRS to less than 60%. If one is going to go up to around 20 to 30 minutes, we think it's a good idea to pack the head in ice just to make sure that it doesn't warm up. And finally, during warming, if you've come close to the limits of what selective cerebral perfusion, or the period of cerebral ischemia, or if you've exceeded it, we think that initial 5 minutes of cold perfusion is effective. In an experimental study, this was shown to have a salutary effect on cerebral functioning of animals after long periods of hypothermic circulatory arrest. We don't always do this. If you have 20, 25 minutes, you can just start in warming. I don't think it's a good idea to start out with hot blood right away. Still, it's important to maintain a relatively low gradient. And probably one of the most important factors is not to warm the patient with blood that's too warm. We have an absolute cutoff of 36.5. I think a lot of people have been harmed in the past by over-rapid warming, perfusing the perhaps a brain that's been subjected to a substantial ischemic insult to cooking temperatures. And finally, if you get very frustrated because the patient won't warm up all the way, you don't have to take the patient up all the way. I've usually over the years, have brought my patients back from the operating room at temperatures of 32 to 33 degrees. And if you bring the esophageal to 35, that's what you'll come out of the OR at. And finally, if you're getting frustrated because it's taking a long time to warm the patient, for the last 15 or 20 minutes, if you go on partial bypass, pulsal flow does seem to improve the efficiency of warming. So in conclusion, you can read these here. Hypothermia is a very useful technique. I think it's, if one could come up with a drug that would achieve what hypothermia does, one could become part of big pharma very quickly and do very well. But it's the best thing we have at the present time, but it does have its limitations, and the way it's done is important in how good the results are. Thank you very much for your attention.